My title is AI for Racial Health Equity. Actually, I debated whether or not there should be a question mark at the end of that, and you'll hear why in the course of my talk. But I want to spend my time with you today presenting some humanities-based context for some of the ethical concerns that we see around using AI for health, and also some of the opportunities, and focusing in particular on the status of race in medicine, medical and health data. I'll address what I see as some of the barriers to using AI to advance racial health equity, and I look forward to your response. So for the first part of my talk, I want to explain how the medical humanities method known as narrative medicine could help to improve the contextual interpretation of data, especially unstructured data for health. I'll also raise some concerns about how that contextual work is being done now. And in the second part of my talk, I will show how the status of race in medical practice raises concerns for data. And I will explain some reasons why we need additional methods for interrogating and critiquing health data for use in AI tool development and deployment. So scholarship in narrative medicine has been going on for some 30 plus years, and it's really, in my view, laid the groundwork for research on narrative in unstructured text in patient records, EHR records in particular, to be mined by AI and ML. There is a clear need for teaching and research on practical and ethical issues in conducting large-scale big data analysis of unstructured text in medicine, in my view, and in the view of many in this field. And this is, I think, a field where AI for health is really poised to expand through collaborations between computer science and humanities disciplines. And that's sort of what I want to present a little bit of today to you. Oops. Oh, there we go. Okay. So why unstructured text? Maybe it's an obvious, there's an obvious answer to that for the people in this room. But from my vantage point and thinking about this through the lens of narrative medicine, medical records are, of course, full of unstructured text, as is, importantly, social media and the internet as a whole. Indeed, although there has been a lot of excitement around analyzing big quantitative data sets in medicine for a number of years now, the reality is that healthcare encounters, of course, occur not only between machines, but primarily between human beings. And we produce a lot of unstructured data in our health communications. So while data from lab results and vital sign measurements might be comparatively easier to work with, the greatest potential promise, I think, of medical AI is in what might be discovered through mining this health-relevant data that has not been well understood to now. And this quote is actually in a piece that was about why Watson Health failed in its sort of first rounds. But what I really wanted to just highlight is the emphasis on how much narrative text is in medical records and the challenge of that. So I know that everyone in this audience knows what natural language processing is, but I want to highlight an element of Google's definition of the term, namely its usefulness in analyzing text and extracting information about people, places, and events to better understand social media sentiment and customer conversations. This information about people, places, and events, when considered in the healthcare context, becomes quite valuable both clinically and financially, and also quite sensitive and in need of privacy protections. Amazon urges their corporate clients to mine their large volumes of voice and text data from emails, text messages, social media news feeds, video, audio, and more, and then use NLP software to automatically process this data, analyze the intent or sentiment in the message, and respond in real time to human communication. As you may well know, Google, Amazon, and all of the other large technology companies believe that these kinds of narrative details, which are often called social determinants of health in medicine, contain valuable information about patients' health and illness. In fact, these companies already have a lot of that kind of data, the so-called subjective statements from their users' search or purchasing histories, and they're looking to use those data sets in partnership with academic medical centers because social determinants of health is currently seen as a site of promise, but also perhaps cynically as a mechanism for cost savings through population health. In different contexts, social determinants of health is also the site of much anti-racist work in medicine and public health. Chandra Ford's work is very important in this regard. So I'm interested in exploring this tension and looking for possible methods to benefit disenfranchised patients using natural language processing. Just to be clear, if this term isn't familiar to everyone in the room, the WHO defines social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So what you can see there is the emphasis on things beyond what are typically measured in clinical encounters. So a major reason that social determinants of health data hold so much appeal for technology companies and health researchers alike is that they provide the fine-grained, nuanced descriptors that give meaning and context to individual lives. Since, as I mentioned, at least the 1970s, scholars in medical and health humanities have recognized the value of personal narratives as sources of perspective on patients' lives, publishing accounts of the value of listening to, reading, and writing what are often called illness narratives. An example of the types of social determinants of health data that can be readily scraped and are being readily scraped, for example, from patient groups on Facebook and many other places online, are on this screen right here. This is a Facebook breast cancer support group that was hacked, but it's barely even hacked because it was readily available and accessible information. And what I want to just emphasize about this list of the different types of data that were available to be scraped is that it's very important information to the patients themselves, but how it is shared and to what ends is not presently being controlled by patients. In fact, they have very little opportunity to have any influence over that, and I think it should be. The patients should have more say in what is done with their personal health data. And indeed, this is happening. You may have heard about this story that came out in June 2022, so just a few months ago, by the investigative journalism group called The Markup, where they found that a tracking tool, a pixel installed on many hospitals' websites, had been collecting patient-sensitive health information, including details about their medical conditions, prescriptions, and doctor's appointments, and sending it to Facebook. And this journalism investigation found that about 33 of Newsweek's top 100 hospitals in the country were actually sending sensitive data to Facebook through this pixel. So this widespread practice of mining patient narratives for exploitable data prompts me to ask, when we talk about patient narratives, who is controlling that narrative? Who owns it literally and figuratively? Who can monetize it? Who can decide whether its contents are true or false, or which parts matter? Sayantani Dasgupta proposed in a piece in The Lancet the concept of narrative humility to address the potentially colonizing effects, as she argued, of a type of narrative medicine that would have physicians or technology companies that develop tools for mining EHRs making all of the decisions about what parts of a patient's story or data set are important and which parts are not. Further, in another piece also published in The Lancet, in a piece called Abolition Medicine, UI and colleagues focused in on language and erasure in these data sets and noted that at the same time that trauma, medical trauma, health trauma, calls forth a need for narration, patient stories are erased, and those stories that do remain are usually reduced to the abbreviated phrases and drop-down menu selections typical of contemporary EHRs with their focus on quantitative data. So perhaps surprisingly, part of what I think companies like Google and Amazon bring to this conversation is a set of ideas about how data and narratives from outside of clinical contexts could help contextualize and interpret clinical signals. But I must note that these companies also bring continued exploitation of patient narratives, and they've been sued for privacy violations for doing so. So I'm not proposing that just a simple turn to technology solutionism is the answer here, but what I want to think through is what their methods might reveal about alternative approaches for researchers and clinicians to pursue equitable, anti-racist, and patient-centered narrative medicine. So in my view, this is where natural language processing comes in for analyzing patient narratives. Some researchers have proposed using sentiment analysis to further this effort. However, and I think this is really key, given the subtleties in representing patient narratives through diverse forms of mediation, NLP methods need to be informed by the perspectives of scholars with expertise in interpretation of narratives in complex, intersubjective, social, cultural contexts, especially for minoritized communities. In one study using this approach that I found interesting, researchers used NLP to mine text and conduct sentiment analysis on a Yelp data set of over 16,000 reviews of US hospitals. Now, there are issues with this study, but the thing that I found interesting was that the researchers found that the majority of reviews expressed patient and caregiver experiences that were not identified by HCAHPS domains, the usual patient survey that's sent out from hospitals all over this country. And this suggested to them that Yelp provided a window into what mattered most to those reviewers in their own words. Others have proposed integrating analysis of clinical records, including unstructured free text, with user-generated content from other social media sites like Twitter, Facebook, Reddit, Instagram, as well as online health communities. So in my view, the importance of narrative and bringing narrative medicine tools into this conversation really comes down to this: to anticipate and prevent harms in the uses of data for future pandemics and also for just day-to-day use in healthcare. We need to let patients speak, and more specifically, let minoritized patients speak. We need, as whether as data scientists or as clinicians or as technology developers, we need to learn how to better listen to them and learn from them on a large systemic scale. We need to figure out ways to activate the large unstructured data sets in EHRs, but by paying attention to what matters most to the patient in that exchange, not only what matters to the MDs or the technology developers or the hospital CEO. NLP may be used to do this, but I think only when new guidelines are developed to ensure that this is done ethically. All right, and so I'll give you a really concrete example of where the ethical issues can go awry in this next section. So I've been arguing for integration of theories and practices of narrative interpretation into large-scale data analysis for the purpose of pursuing digital health equity. But these narratives must be understood as products of patients and products of a racist medical system. And I don't say that to be inflammatory. There's plenty of documentation of this. It is probably well known to the people in this audience, it may be, that despite extensive scholarship demonstrating the lack of a biological or genomic basis for race and ongoing evidence of the severe harms caused by the perpetration of racist ideas in medicine, nonetheless, medical training and clinical practice to this day use race frequently as a factor in implicit and explicit ways. So, in fact, the first line of a 2020 article in the New England Journal of Medicine describing the ongoing use of so-called race correction algorithms in medicine was this: physicians still lack consensus on the meaning of race. The authors go on to explain, one subtle insertion of race into medicine involves diagnostic algorithms and practice guidelines that adjust or correct their outputs on the basis of a patient's race or ethnicity. Physicians use these algorithms to individualize risk assessment and guide clinical decisions. By embedding race into the basic data and decisions of healthcare, these algorithms propagate race-based medicine. And most importantly, many of these race-adjusted algorithms guide decisions in ways that may direct more attention or resources to white patients than to members of racial and ethnic minorities. Now, you don't need to be able to read this. I just wanted you to see how many examples they were able to provide. Thanks to the work of scholars like Alondra Nelson, Lundy Braun, Latanya Sweeney, Safiya Noble, Joy Boylamwini, Ruha Benjamin, and others, we know about the kinds of racial profiling that can be baked into devices and data sets which can cause racist output in their algorithms. But we have to ask, why are these race correction algorithms still in use in medicine? While quite a few of these algorithms have been identified and scrutinized for their faulty assumptions and harmful effects, a lot of AI tools are being developed and deployed based on proprietary data sets that are not available for analysis and that may be reproducing these racist models potentially without even realizing it. And one of the consequences of this is that they may be actually building on the promise of social determinants of health, but inadvertently turning that tool against the very patients that it should be mobilized to help. So just a couple of examples of the kinds of tools that are probably familiar to everyone here that may have this effect. Tools that are designed to do risk profiling, they may have, have good intentions, but one of the things that they can often do is highlight ways that people need additional resources, but instead frame that as making them poor risks. So for example, data brokers like LexisNexis and Axiom already sell social determinants of health data to healthcare and insurance systems, and they include information on criminal records, online purchasing histories, retail loyalty programs, voter registration data, and more. And they have statements like this one that kind of reframe a person's individual past as an indicator of whether or not they actually care about their health. That's what I mean by turning social determinants of health against the people who it's meant to help. This is just another example from those advertising materials of the way that the different kinds of categories that are brought forth as social determinants of health data, but then are not used to bring additional resources to the patients. Now, some of these algorithms have been analyzed by researchers and published, and important pieces have been published kind of showing how this works. There was a famous Obermeyer piece that came out in Science in 2019, you may be familiar, and Ruha Benjamin wrote a great editorial about that, showing how risk profiling algorithms can reproduce systemic racism. And this work is very important, but as I mentioned, so many of these data sets are proprietary that it's not very easy to do in a kind of systematic way. So this is a story from just yesterday. I thought I would bring it in to the talk. When we consider movements to develop AI systems like this is Dragon Ambient Experience, or DAX, which is sold by Nuance Communications, a Microsoft subsidiary. This is a tool, an AI tool that's meant to record and automatically transcribe what are considered the important parts of a doctor-patient encounter. And this is where, I'm highlighting who decides what's important, I think, is a really key question that we haven't been asking enough. So for patients who already experience race-based decision-making without being informed, this kind of tool might raise really serious concerns, and we have to think that through. So in closing, while the threats to patient privacy and autonomy by these tools that exploit health-relevant data sets are real, the need for capturing patient voices that have been systematically excluded from those data sets is also real. Racial signifiers pervade the unstructured data and logic of EHRs and the algorithms that drive them, and these complex data sets are at the center of efforts to develop AI for healthcare. So I hope that this sketch shows why we need to draw from humanities-based understandings of narrative, ethics, and histories of digital inequality to be integrated with computational tools of NLP and AI. And I hope that some of the researchers in this conference might pursue these kinds of collaborations with humanities researchers to bring new perspectives to the real value that might lay within unstructured patient data sets. And this last image I'm leaving you with was generated by DAL E2 based on the title of my talk. Thank you.
Thank you. We probably have time for one quick question. Okay.
Is there any regulatory body at this point for looking at how NLP, how algorithms use NLP and reduce data?
No, I mean, and there's not even the only regulations that govern the uses of medical data is HIPAA, which is very outdated because it was developed in a time really before the digital world that we live in. And that only governs very narrowly defined medical data captured in clinical context. So it doesn't govern anything that happens outside of those settings. So these are debates that are happening in Congress right now, but right now, no, there's nothing.
All right, thank you so much.
Thank you.